All right, hi everyone. I just wanted to present a quick video of four interesting cases I saw on consults a few weeks ago, going back on service tomorrow. So it reminded me to share these with you. Um, so here we go. This is the first case. This was actually a really interesting case. What do you have here? This is the right lower extremity. It's medial malleolus. We have a full thickness ulceration with the surrounding pink to inflammatory edge. So this isn't something that you could just look at and have an instant diagnosis for or be able to immediately categorize, but I want you to be able to put it into different differential diagnoses or possible etiologies for an ulcer. Ulcers are tough, but at the end of the day, there's only so many things that can cause them. So, walking through possible causes of an ulcer and seeing if it makes sense for this case, first thing you want to think about with an ulcer that comes up in dermatology almost all the time is an inflammatory ulcer. So, the prototypic inflammatory ulcer is pyoderma gangrenosum, where you get a neutrophilic infiltrate, which infiltrates the skin, causes damage to the skin, full thickness ulceration. With that, you're usually going to see full thickness ulceration and inflammatory borders. So this absolutely could be consistent with that. Usually you're going to have a little bit more of an undermined border, a little bit more purple. If you're going to have a full thickness ulceration like this, usually you're going to get a history of very painful, tender ulcer that's going to develop quickly. But that's your kind of prototypic inflammatory ulcer is pyoderma gangrenosum, but it can be an ulcer also that occurs in a patient who has lupus or rheumatoid arthritis or whatever. Maybe we don't always call it pyoderma gangrenosum, but if it's an inflammatory infiltrate that's causing ulcerations being driven by an underlying syndrome, that's what it is. Other possibilities would be neoplasm. You have to think about a long-standing ulcer. You want to think about neoplastic etiologies, so squamous cell carcinoma, lymphoma, melanoma can look ulcerative as well. Those you're going to get a little bit more of a clinical clue for those etiologies when the border is a little bit more heaped up and friable. Here it's pretty frankly ulcerative, so it's going to be less favored, but not out of the question. Besides inflammatory and neoplastic, other etiologies you have to think about factitious. Is the patient doing this to themselves? Drug-induced, so classic triggers for drug-induced ulcerations are hydroxyurea. You also can think about foscarnet as well. It's usually going to give you penile ulcerations. Any cytotoxic chemotherapy, which kills the cells and causes cellular breakdown, can give you ulcerations as well. Besides drug-induced, you're going to think about vascular, so venous or arterial. This being on the medial aspect of the malleolus is going to be better for venous. It's also pretty kind of wet and purulent. I should say purulent, more like fibrinous, which is going to be better for venous, whereas arterial is going to be kind of dry. It's going to be lateral malleolus. Look for existing clues. If you think that this is truly a venous ulcer, you're usually going to have venous insufficiency. There's some mild scale here, but there's not too much brawny dyspigmentation or stasis dermatitis. Same for arterial. If you think there's arterial disease, you're going to see alopecia or hair loss of the lower extremities. They're going to look kind of shiny and taut. We don't really see that as well. So those are some of the most common causes of ulcerations: inflammatory, neoplastic, factitious, drug-induced, vascular, among others. There's probably some other categories that I'm missing, but those are the ones that you're really going to think about. So in this case, it was interesting. It was actually a patient who had a history of myelodysplastic syndrome who was on hydroxyurea for years. And we did biopsies, which were fairly nonspecific. Oh, actually, that brings me to the one category I forgot, which is infectious, because I was just remembering we did biopsies for H&E and culture. So infectious causes of ulceration. So any deep infectious cause, either bacterial, fungal, viral, even protozoal, can give you ulcerations as well. So we biopsied this. Culture stayed negative, stayed sterile. Biopsy was very nonspecific. We did a workup for inflammatory ulcerations like pyoderma gangrenosum, which was negative. We did a vascular workup for venous and arterial etiologies, which was negative. So we actually ended up rendering the diagnosis of hydroxyurea-induced ulceration. Kind of interesting. Only the second case I've seen of it. It's a diagnosis of exclusion, like many things in dermatology. And interestingly, I reviewed the original series that described this, and 70% of cases occur on the medial malleolus. And often there's a lag between stopping the medicine and having resolution. The patients who develop these are classically chronically on these medicines. So they're on hydroxyurea for many years. So if someone just starts it and has an ulceration, that's unlikely to be the cause. It's thought to be due to the fact that hydroxyurea is a cytotoxic agent, just causing direct microvascular injury, which leads to an ulceration. And the thought is, even though there's a delay, if you stop the medicine, you should eventually get resolution with wound care. So this was a hydroxyurea-induced ulceration, which I thought was a pretty cool case. This was another really interesting case, actually. A little bit of a stumper, but if you look at it carefully, I think we can get there. So this is a 60 or 70-year-old man who's presenting with these pink papules. And these pink papules, you can see, are not random. They're distributed in a certain fashion. So they're here on his cheeks. Laterally, they go over his malar cheeks on top of his nasal bridge. There's some nasolabial fold sparing. And what I think is very important here is that there's involvement of these pink papules on the neck. So it extends from the lateral neck down to kind of the superior aspect of the chest here. Interestingly, this patient had presented with fevers, found to be pancytopenic, liver damage, malaise, arthralgias as well. So putting the clinical constellation together is a patient who's sick, has serologic abnormalities, is having systemic abnormalities, and then has a photo-distributed, look at that nice upper cheek going over the dorsal nose, photo-distributed pink papular rash. You want to be most concerned for connective tissue disease. What's interesting is we had that in our differential, but we were also considering seborrheic dermatitis, which is going to be a central facial dermatitis or dermatosis as well. What I think should point you away from that, obviously besides retrospect and the biopsy findings, are the involvement of the neck here. So seborrheic dermatitis is really going to be kind of T-zone, like forehead, nose, cheeks, beard, or jawline, but really shouldn't be kind of neck area like that. That's going to be a little unusual. So that constellation of findings should put you in a different bucket. And this was the interface dermatitis or connective tissue disease bucket. So we diagnosed this patient with acute cutaneous lupus because of the malar butterfly rash and photo-distributed pink papules. And he had subsequent serologies that confirmed the diagnosis of systemic lupus. This was kind of a cool case. We've talked about reaction patterns in different videos, but this is one of those things I think you just have to get a clinical gestalt for. This was a patient who was overall well, admitted for other reasons, who presented for this rash, and we were consulted to kind of understand what was going on. It was completely asymptomatic, not bothering the patient, and the team was just worried about like a drug rash or something like that. And what's interesting here, you see these kind of confluent pink papules, some plaques, in a reticulated array on the extensor knees. So you can kind of appreciate that these aren't randomly distributed, but they are kind of in a net-like array. So you'll have lesions, you'll have clearing, lesions clearing, lesions clearing, like in a reticular or retiform even array. And what's interesting also is you can see that there's a little bit of dermal substance to it. So these kind of look edematous, they look juicy, they look kind of broad and plaque-like. And so when you have a broad plaque-like extensor-based reticulated array, really there's not too much that causes this, and this is a viral exanthum. Viral exanthum, can really look like anything. It's polymorphous. You can get these papules, you can get edematous plaques, vesicles, pustules, but a reticulated array or reticular array, you really want to think about viral, and the high yield one to know about is parvovirus. Parvovirus or erythema infectiosum, when it occurs acutely often in kids, we think about the slap cheek appearance, but upon resolution of the rash, you'll get a reticulated appearance. And so this reticulated rash is concerning for virus. It's okay though, because at the time that you develop the rash, the patient is no longer contagious. Last case, really common thing we see in the hospital. This was a patient for whom we're consulted for bilateral cellulitis, LOL. But, it might be obvious to us, but it's not obvious to everyone else that that's going to be a very unlikely possibility. So what's going on here? You see that the patient has swelling of both lower extremities, marked erythema, flaccid vesiculation. So putting it all together, this is inflammatory dermatosis of the bilateral lower extremities in someone who's swollen with secondary blistering. This is chronic. I shouldn't say chronic, this is acute stasis dermatitis. And it kind of makes sense pathomechanistically. The patient has swelling, the swelling stretches the veins leak. When the veins leak, blood leaks into the dermis, which leads to an inflammatory response. So the swelling probably caused the erythema, and eventually the fluid interstitially had nowhere to go, so it just pushes up in the skin and gives you these blisters. So bilateral erythema, vesiculation, and swelling is good for chronic stasis dermatitis. And that is it for now. There's just 4 cases. I'm sure after I go on a consult starting tomorrow, we'll have some more cases. Hopefully you found this helpful. Try to do this in about 10 minutes, just some good learning points for you. If you find it helpful, please like and subscribe to the channel.